Enjoy your meeting.
Some of the stuff may be old hat for you. I was asked to address the implicit network around some of the stuff that
Just a reminder, today's meeting is being recorded.
Very good. It's being recorded. To just kind of update all of you, and so that you can continue to reflect of what the interconception care work that we've been doing with implicit, how that fits in and all the opportunities that we are faced with on the national front to think about. I want you, as I speak, I want you all in the implicit network to think about ways that we can continue to capitalize on the opportunities on the local, regional, state, and national level of the work that we're doing. So for some of you that don't know, I'm a family physician here at MAHEC, the Mountain Area Health Education Center in Asheville, North Carolina. I'm a family medicine resident educator, and I've been doing the implicit model of care for the last 5 years here. And as a part of that, at one of our meetings several years ago, our March of Dimes colleagues invited us to participate in the National Preconception Health and Healthcare Initiative. And after raising my hand, I got involved in this initiative, and within 1 year, I was able to take the reins and take a bigger role. And so I'm currently the co-chair of the clinical working group of this national initiative, and I've been able to participate in a wider reach of initiatives, and that I'm trying to give you a flavor of what some of those are. There's a lot of stuff going on nationally and statewide, and so hopefully I will inspire you to get more involved. So what I'm going to cover today is just kind of describe the vision, goals, and key directions and resources that are going on nationally. I'm really going to focus on the main work that I've been doing is trying to promote clinical measures of preconception wellness, and then share some ideas for holding different sectors and us partnering, especially with public health, for improving quality of preconception care. So the national initiative has a vision that all women and men of reproductive age will achieve optimal health and wellness, fostering a healthy life course for them and any children they may have. Its goals are to improve the knowledge, attitudes, and behaviors of men and women related to preconception health, that all pregnancies are intended and planned, to build health equity and eliminate disparities in birth outcomes, to ensure that all women and men of reproductive age receive quality services that enable them to achieve high levels of wellness, minimize risks, and enter any pregnancy they might have in optimal health, and then to reduce risks among women who have had a prior adverse maternal, fetal, or infant outcome through interventions through the postpartum and interconception care period. So that's the national vision and national goals of the Preconception Health and Healthcare Initiative. Its purpose, it's a public-private partnership. It's been around since 2004, and many of you may recall that it was the founding member of that preconception select committee that came out with the MMWR CDC recommendations for including preconception health into primary care. It's been working on that ever since. Its goal is to foster connection and push momentum, to multiply local impact through national collaborative efforts, and to support development of key preconception care resources, science, policy, surveillance, and messaging. So just to step back a bit of what I've learned, and some of you may know this and some of you may not, but on the national front, the HRSA Maternal Child Health Bureau has really, in the last couple of years, put a focus on infant mortality, and this is where some of that momentum and that tipping point of opportunity has come, is that the COIN initiative, which is an initiative, a learning collaborative out of the HRSA MCHB Bureau, has expanded its scope to interconception care as a way to reduce infant mortality, and about 30 states have chosen this as one of their primary modes to be working on, many of them working on LARC initiatives and the One Key Question initiatives in order to drive this movement forward. The other part of MCHB is Title V, And I've been learning a lot about the different public health organizations and the funding streams. Title V apparently is the oldest federal state partnership that exists. And it's really a block grant to all 59 states and territories with its goal of improving maternal child health. And again, it has a large focus on reduction of infant mortality. This year is they're coming to the end of their 5-year process, and so all the states are currently in the process of putting forward their next 5-year strategic plans. And being a part of this national initiative, we've been technical advisors to the states on as they are using their strategic plans to choose initiatives. One of them is how to improve the use of the annual wellness visit for women, and really thinking kind of how to actually maximize this from Title V funds from states to do this well. So, talking about the Well Woman visit from the national initiative perspective, there's 5 working groups in this national initiative, and so we're trying to maximize how all these different foci can be working together for a single purpose of where the overlaps are. So, around the Well Woman visit is a prime example of how we're trying to have that cross-cutting opportunity. So, for the consumer working group, they're actively working on an education about the importance of women's wellness, the covered services, and the quality of care to be expected to create activated patients and clients. On the provider work group, that's where I am. We are working actively to encourage the use of reproductive life plan and one key question as a strategy, and then establishing these preconception wellness measures to drive improvements. On the policy side work group, they're developing measures and metrics to hold providers and health systems accountable for delivering care. On the population surveillance and data group, they're creating more streamlined benchmarks for monitoring and assessing national improvements in health and birth outcomes over time. And then the public health work group is working on resource alignment, and this is where that national performance measure for the Title V block grant can come in. So another area that has really bubbled to the forefront on all of these initiatives is the concept of reproductive justice and the importance that we all play as maternal child health providers who are working on infant mortality reduction. So I just wanted to throw this out there as the idea that when all people have the social, political, and economic power and resources to make healthy decisions about their gender, bodies, sexuality, and families for themselves and their communities, then we have achieved reproductive justice. This is a link to a great resource around this, and I wanted to highlight one of the key papers that has come out recently to really a call to action to all of us maternal child health advocates of the role that we play in the work that we're doing to achieve health equity. And so I would really encourage you to take a look at this commentary, this white paper in Maternal Child Health that was written by my colleagues Sarah Verbeest and Kiko Malin and Mario Drummons and Milt Kotelchuk, all of which are a part of this national initiative and been doing this work for a long time. It really talks about bringing together the life course theory, preconception health, and social justice reproductive equity to advance our ultimate goals of reducing infant mortality and improving birth outcomes. Another big facet of what the Preconception Health and Healthcare Initiative is working towards is the consumer activation piece, and these are screenshots from the new and improved Show Your Love Today campaign. It is really targeted towards consumers with specific messaging around getting our patients to learn about how to improve their own health and present themselves to healthcare resources that are appropriate for them. There's a lot of kind of social marketing campaign that has been happening recently with some new resources that our initiative has had. And so all of the folks that are involved in Twitter or Facebook or other social media, this is a great way to engage in the conversation and be a part of advancing the message to our communities. Another thing that is happening is this idea of a well woman story. And so there's a group that is out of Chicago that is working on collecting stories of what it means to be a well woman, what kind of experiences they have in receiving this kind of care, in order to really understand and bridge the gap between the medical community and patients themselves. So anybody who is interested or has patients that might be interested, this is a phone number that can be called where women can actually record their own stories and their own perspectives on this issue. So I'm going to turn focus on the main core of my time has been really trying to promote, to develop and to promote these clinical measures of preconception wellness. So just taking a step back, all of you knows this quote well, I'm sure, from Don Berwick. Every system is perfectly designed to achieve exactly the results that it gets. And so I like to start this way for all of our policymakers because it really drives home the point that our system currently is high costs, rising maternal mortality, and stagnant infant mortality, and it really should be a call to arms and create a sense of urgency for system change. So for preconception healthcare, there has been momentum for every woman, every time, that idea as a call for providing evidence-based preventive care to all women and men of childbearing potential as a gateway to higher levels of wellness, whether or not pregnancy ever occurs. Of course, our model of interconception care at Well Child Visits is exactly this type of care. The promotion of screening around pregnancy intention is essential for both well women and acute care, including hospital discharge, and not just something that is done at a preventive visit once a year. And to increase the capacity of healthcare providers and systems to integrate and monitor preconception care services through routine, preventive, primary, and specialty care. That is the focus of the clinical work group right now. So again, if you can't measure something, you can't understand it. If you can't understand it, you can't control it. If you can't control it, you can't improve it. It's one of our goals, and we understand the value of quality improvement in data. Even though it's really hard, it is really an important part of driving improvements forward. And so when we think about preconception care, there really isn't anything out there right now. It's one of the reasons why, and theoretically, that we have had trouble in moving preconception care initiatives and progress forward. And so if we think about what are we currently measuring, what is CMS focusing on, what are all these measures that we're being inundated with? Our current quality measures focus on three different areas. One is chronic disease management and preventive service delivery. For example, we're being monitored on our immunization rates. We're monitoring on BMI assessment and dietary counseling, tobacco screening and counseling, our hypertension, diabetes, CHF, screening, management, and target goals, our cervical cancer, breast cancer, and colon cancer screening. But really none of these measures, if you look at them, all the ones that we are reporting upon, focus on reproductive age women as a special group. Other things that we're reporting on and trying to achieve, patient-centered medical home, electronic prescribing, using registries, making sure that we have patient portal communications and medication reconciliations, and then we have ones that are focused on patient satisfaction and shared decision-making. So we have all these measures that are currently being integrated into the system of clinical care that we provide. But again, where's the preconception care measures? So for pregnancy outcomes, we've had ones for several years, really about access. The federally qualified health centers have always been reporting on first trimester access. We have 17P quality initiatives. We have STI screening as a quality initiative. There's a lot of efforts around intrapartum management, such as the no elective deliveries before 39 weeks, the hemorrhage bundles, and reduction of low-risk C-section rates. And then, of course, the main place where we've been reporting outcomes is at the birth, such as APCARs, using the Vermont criteria, and prematurity and birth weights, and then infant mortality and maternal morbidity mortality. That's been our primary driver of data for a long time. So when we think about preconception care, there really isn't anything specifically designed to measure the quality of preconception care, even though we all recognize of how important it is. But if you actually look back on all these measures that we are doing, they actually are. Many of these are all preconception care, because good preconception care starts with good women's health. So all the immunizations, the BMI, the depression screening, tobacco, infection screening, diabetes management, these are all preconception care. If we look at it that way. If we don't look at it that way, it could be a marker of poor preconception care. And so we want to start to change that paradigm of how we look at some of these quality measures. In order to do that, we had to kind of think about some definitions. So preconception care we defined as the care provided to promote and achieve preconception wellness. Preconception wellness is a term that has been used, but we kind of are kind of trying to focus it as being the state of a woman's health at the time of conception. So the goal of preconception care is to improve preconception wellness. So one of the reasons why preconception care has been so hard to quantify and measure is that it's provided in multiple settings across clinical and public health sectors. There's social determinants of health factors that are not necessarily in the clinical control. And so it's difficult to measure and then difficult to hold any one group or domain accountable to its results. So we start off with an aim statement, or a statement of that we agree upon, that women, based on our system results, that we have rising maternal mortality, we have poor infant mortality compared to other countries, and that we aren't seeing the improvements, and that one of the main areas that we have all agreed upon in this group, I don't need to sell it to you, that preconception care, interconception care, is a main place that we can drive improvements on both of those numbers. So we need to agree upon that women are not achieving a high level of preconception wellness upon entering pregnancy. So how could we possibly choose to measure that? And one idea is that an intermediate measure of a woman's preconception wellness upon entering pregnancy would serve as a surrogate marker of the state of preconception care in the community, which then could be to drive decisions on processes, programs, and quality improvement further upstream. So starting to measure something at some point is where we are. We met as a consensus panel with broad expert representation. This was about a year and a half ago. We had MFMs and family medicine and OBGYN and nurse midwives and public health representatives and nursing all at the table to try to answer this question: can we measure preconception wellness? We reviewed the available evidence around preconception care recommendations. We looked at the current quality measures around HEDIS and NCQA and NQF and ACO measures and all these measures to see what currently is being used that we could co-opt so that we weren't creating something new. We looked at the feasibility in the current EHR collection practices and really trying to focus out which measures would most impact perinatal outcomes. So this article has come out now. It is a free, it's open source article out of the Green Journal. So I would encourage you to take a look at it if this interests you. It includes a table describing each of the measure, its intent, its reported data and target, and how it compares to existing measures. And the idea is that it's supposed to be reported at the first prenatal assessment as a surrogate for preconception wellness and an indicator for the receipt of preconception care prior to pregnancy. So this is what flushed out, is that we started out with 25 or more possible measures for preconception wellness. And what we determined is that one concept is that no single measure alone was sufficient to describe preconception wellness. Is that even if you got pregnant with an intended pregnancy, that doesn't necessarily mean that you received great preconception care and were well at the time of that conception. even if you were tobacco-free at the time of pregnancy. It doesn't mean you were preconceptionally well at the time of conception. And so what we were able to do is boil it down to a minimum of 9, although we wanted 1. We were able to boil it down from 25 to 9. But in aggregate, we felt that these could, if used, could adequately describe preconception wellness. And so the good thing about this that we found is that 6 out of the 9 are already standard of care and routinely being reported, and so shouldn't disrupt the workflow or EHRs, and so it's just a matter of reporting them slightly differently in this group. 3 of them, monitoring and reporting upon pregnancy intention, monitoring and reporting on the use of folic acid and multivitamins prior to pregnancy, and the monitoring and reporting upon medications that are teratogenic that they were on at the time of conception. These require a slight change in workflow and EHR, but certainly are feasible to do. So what we are trying to ask is for systems to take these on as measures of preconception wellness, that then, once you start to get these reported, they can serve as the community's baseline, benchmark, of where to focus their efforts to improve preconception care efforts in that particular community. So this kind of is a graphic of kind of putting it all together, that we know that women's health is influenced by many factors. So there's the clinic-based delivery of health care, there's the medical system, there's the public health and community efforts, there's the social determinants of health, and then there's the patient herself and the role she plays in self-activation and responsibility. So before, and I'm going to use this little arrow, that we're only focusing on measuring and reporting on in the front end around chronic disease control and preventive health care, but not with the focus of reproductive health. And then on the back end, on the birth outcomes, infant mortality, maternal mortality, preterm birth rates, elective deliveries. And so we are suggesting is this intermediate time point to focus particularly around preconception wellness, that then would be able to focus the preconception care efforts that this domain affects. So that is the idea. So how do we do this? Again, so now just kind of putting this in the framework in the trenches, there's a lot of talk about reproductive life planning and how we can start incorporating this into the care we provide. And so the life plan, which includes reproduction, is all about getting our patients to think about what is their goals, what are their career goals, their education goals, their family and reproductive health goals, all of these to really have more planning and intention about how they're living their life. That's a hard concept for most of us even to get around. The reproductive plan, we're starting to focus more, it's a little easier to think about what is my reproductive plan for the next 1 to 2 years. I may not be able to have a plan for the rest of my life, but I can think about what do I want in the next 1 to 2 years. But even that can be challenging, and with our unintended pregnancy rates of 45% in the country. And so this idea of the reproductive action plan now, so that's the opportunistic triage of risk. Again, this is what we're doing in the implicit interconception care model, of really talking to them, to mothers, saying, okay, are you on birth control? This is why optimal birth spacing. This is why it's important. What is your plan now? How can I help you achieve that goal? Even though this visit isn't meant for that. And so we are trying to expand that through the one key question approach, which is anytime women come in for whatever type of care, to be asking those types of questions and helping them connect to optimize their health. Of course, providing preconception care in the context of a busy primary care clinic is difficult. There's a lot of education that still needs to be done, and so I do want to draw your attention. If some of you have used this site, please give us feedback. For those of you who don't know about this site, this is our national resource on beforeandbeyond.org. This is meant to be a one-stop shop for evidence-based guidance around what is preconception care and and what kind of questions and things we should be thinking about. It's really guided and founded in the one key question around would you like to become pregnant the next year, and the answer to that being focused around what your focus should be with that patient. Now, the one key question really is designed to be used to hopefully focus on contraception and identify those women who are at risk for unintended pregnancy, as well as those who are desiring pregnancy. But the preconception care component of the one key question is challenging and still hasn't quite been fleshed out. And so, the reason is preconception care, as we all know, is quite comprehensive. It's well woman care. It's providing all these domains and thinking about what risks that an individual patient might have. And that may be very difficult to do within the context of a routine primary care visit. This resource is meant to help guide that. It's the toolkit content is guided around the 10 clinical areas of preconception care. Its content is subdivided into the background, clinical guidance, clinical tools, patient resources, and references, and it has a summary PDF that can, for quick review. I have found that this is really valuable in a residency clinic when residents come in and say, this patient is interested in becoming pregnancy, but I have no idea where to start to talk to her about her risks. Using this as a framework to think about that is very helpful. It needs more resources. It's called a toolkit, but it's not really a toolkit. It's really a evidence-based guidance resource. And so what we're trying to do and develop is more tools of actually how to do this well. And so your help and assistance in this would be appreciated. So what are those tools that we're thinking about that we need? We need more billing and coding reference sheets and guidance of how to actually incorporate this into routine care and optimize our collection for the time that it requires to do it. We need more engagement in patients. It would be great if our patients in the waiting room were already doing risk assessments and were presenting themselves to us, already thinking about what their needs and goals are. That would be a really great addition to patient-centered delivery of care. And so the national initiative is working with the consumer work group, the clinical work group, and the consumer work group. This year we'll be trying to partner on what that might look like. And then more algorithms of developing these easy-to-read algorithms to assist them in what priorities of preconception care can be done within the context of that acute opportunistic visit. If you only have an additional few minutes, which one of those 10 categories is the most important to address, and which ones can be left till later. So, stepping back about one of the national resources, so Title 10 is the funding stream for family planning for states. Different organizations get this funding, health departments, FQHCs, Planned Parenthood, various locations. And in 2014, many of you may be aware of this and have read this. They really came out with a great comprehensive evidence-based guide and recommendations for providing quality family planning services. And the reason why I bring this up is that for the first time, they really focused on this idea of preconception health as a part of family planning, which really was never a big driver. So I call this the every client, every time quality family planning styles. That I've been able to be a part of the rework of this document. And as we are talking and thinking about what really is preconception health, that really most of preconception health is well woman care, that not siloing it off into a separate element that is extra. When you're talking about family planning is one of the ideas that we are kicking around. And so I have this preconception health circle is where it currently stands in the algorithm, but really sexually transmitted diseases is part of preconception health. So if we draw a circle around that, that's all preconception health. And then they have over here in this side section the chronic care management and preventive services and assess the need for services related to preventing or achieving pregnancy. That's also all preconception health. So really, this entire algorithm really needs to be focused on preconception health and really getting that idea around that what we are providing is preconception health, and part of preconception health is assessing for contraceptive needs, optimizing birth spacing and education around that, and then chronic disease management and risks when it comes to reproductive health, that all of these are one big package and shouldn't be siloed apart and thought about separately. So quality family planning really equals quality preconception care, which equals quality women's health. And so that's some of the conversations that are happening around Title 10 and family planning, along with those other Title 5 and COIN and the other federal and state initiatives. So I mentioned that one key question is has a challenge with what to do with the yes answer or the okay either way. And so we've been working with them to redevelop an algorithm of what does this really look like if you're asking this one key question in the context of routine care, and how to prioritize what that intervention should look like. So this is hot off the presses. It's not completely agreed upon, but this is the latest version, and I would love your comments and suggestions for improving upon it. So you're my test audience on getting feedback for this. So as we know that the one key question starts out with, would you like to become pregnant the next year? And there really is 4 different possible responses. And if you look at this box over on the side, is that as a provider, what we should be thinking is that how does this patient's response to this question, how does it influence the medical decision that we have with them around their prescriptions, their follow-up care, their preventive reproductive health services that we are currently providing or need to provide in the context of that visit. So really kind of framing our decision-making with them, the shared decision-making based on their interests, desires, or risks. So part of that needs to include a review of chronic health conditions. Are they diabetic and are interested in pregnancy? Are they diabetic and unsure, or they don't want pregnancy, but yet they're not on a lark? So are there any urgent psychosocial concerns? Are they actively depressed? Are they actively abusing drugs? How does that, or are they actively in an abusive relationship? How does that affect how we think about their answer to this question and how we can help them achieve the goals they're looking for? And then really elevating the idea that a multivitamin with folic acid should really be recommended for all women of reproductive age, regardless of pregnancy intention. So on the path on this side, although all of these 6 boxes are really can be thought about in the context of any answer, if it's more on the yes side or okay either way, we're looking at their medications and seeing if we need to make any changes in the moment. We're reviewing birth spacing recommendations and optimal timing, not optional, optimal timing for wellness, and develop follow-up plan for additional preconception care. So we can't provide all of preconception care in the context of this visit. So we want to develop that plan and have it come back for that more comprehensive preconception care visit. So if they're in the no category, we're really more focusing on their contraceptive use, but not forgetting about these other issues that may impact that, assessing their satisfaction of method and the compliance of use and the review of that effectiveness. So really that just their satisfaction and compliance may not be the end of the conversation if they have a high-risk condition or on a high-risk med. That conversation may look a little differently. And then making sure that we're including emergency contraception in our routine provision of that care. The last little few things I want to just bring up, this just came up to my attention as I was searching for creating a budget and a proposal for our state around covering our implicit model for what we're doing within the context of well-child visits. This is the holy grail of our ability to really promote interconception care at well-child visits. Is everybody keeps saying, but does it get paid for? But does it get paid for? But does it get paid for? So the great news, and I wasn't aware of this until I was researching this, is that CMS just came out with this advisory bulletin to Medicaid of all states that really is recommending maternal depression screening and treatment being covered under the child's Medicaid. And I would argue that tobacco and tobacco counseling should also be covered under the Medicaid, and this comments on that as well. And so if this can be a platform of a conversation with our state Medicaid, this could really be the turning point for introduction of interconception care into routine well child care more widely. So the last little thing is that I want to invite all of you is that about 2 years ago, maybe it's a year and a half ago, at an FMEC meeting, I was sitting around with a group of people, and we were lamenting the AAFP's national role in preconception care efforts, and we were inspired, multiple ones of us around the table. And what ended up happening after that meeting was a letter to key leaders, including the president of the AAFP, which then led to a discussion, which then led to the preconception care position paper that was published. And so I think that there is lots of opportunity for all of us to engage our leadership and our national organization around moving this idea forward on a bigger scale. So this preconception care position paper was published, and so the thing I want to ask all of you is that what do we do next? So we have this, we have momentum, we have interest, we have buy-in from the AAFP now, and so the next request that I've been working with them is that, okay, well, should there be a CME bulletin that they send out? Should there be some other modules that the AAFP is promoting and engaged upon to really engage and encourage all family physicians to take this on as a part of their routine care? So I haven't felt the response yet, and so if anybody has ideas or ways to move this momentum forward and capitalize on the work that we've just done with the preconception care position paper, I would be very interested in hearing them. I do think that we have the ability to affect change, and particularly around our experience with the interconception care model and our relationship with the March of Dimes, and trying to improve the AAFP's relationship with the March of Dimes on a national level. So that's all I've got, and I would really love to open it up to hear discussions, comments, other thoughts and ideas. Anybody who wants to get involved or has thoughts around the national initiative, Sarah Verbeest is the main guru and leader of the ship. And so I encourage you to email her directly about your thoughts, but certainly I can be a conduit of that as well. So that is all I have. So I hope that this will be inspiring and give lots of thought and of ways that you can get involved on a bigger level. So please shout out your questions or comments or thoughts. Thanks.
Hi, Dan. This is Ian. Thanks so much for that excellent presentation. You mentioned behavioral health and mental health issues, and you know that's a particular interest of mine. Are there specific things that the national campaign has kind of framed with regard to mental health for preconception care?
As a separate initiative, I don't believe there is anything going on particularly around that, other than the fact that it's a part of the preconception care panel of issues, and the idea of reproductive justice and the importance of mental health issues around health equity is a part of those discussions. But there, other than us promoting the depression screening and treatment as part of the surrogate markers, there isn't anything currently that I know that is a big initiative.
This is Steve. It's just building upon an email that Dan forwarded to us about CMS. Dan, if my memory is right, there are 12 states that are beginning to reimburse well child care for doing depression screening at certain intervals. That was kind of a major new revelation. So I think it's something that we need to explore how to tie into the ICC model and see what our pediatric colleagues, how they're responding to this ability to provide some enhanced reimbursement for doing depression screening.
Is anybody in a state that is currently reimbursing that you're aware of?
Oh, I'm sorry, I think I missed that email. Is that an email that you sent out fairly recently, Dan?
Yeah, no, I just sent it out. Jessica is going to send out that CMS. I just got it like a couple of days ago. Okay. And so I just sent it off to Steve just to let him know, and Jessica to send it off to the group. So that'll be coming. So you can see that brief from CMS.
So Dan, let me just jump in. I have two things. I'm a little curious when you looked at the 9 parameters that looked at kind of the state of preconception care at the beginning of pregnancy. I was a bit surprised to see that pregnancy interval was not one of those 9 areas. And I don't need to go any further. You maybe could comment on that first of all.
Yeah. So there, again, there was 25 areas, and of course, birth spacing is one of those. I mean, there are many others that are. I mean, all of them are important. So every single one issue that would improve birth outcomes is important. And so we were challenged with the fact of trying to pare it down to ones that could the least number that would adequately describe it. And so we tried to also maximize which ones may be influenced by others. So the idea of birth spacing might be influenced by pregnancy and tenderness and the inter first trimester pregnancy care, as well as being on a folic acid prior to pregnancy. So birth spacing may be influenced, maybe reflected in the other measures if they were negative or positive, depending on which way you look at it. So the goal was to try to maximize the number of measures that could be reflected in other measures, if that makes any sense. The paper does describe our process of how we came to these ones, but again, it's not a reflection that ones that weren't chosen weren't important.
Hey, it's Lisa Schlar. Nice job, Dan. I love the review, and I'm assuming we'll get a copy of that because some of those slides are just awesome. I think I told you earlier that one of our seniors is going to take on One Key Question as a QI initiative in our office, and her algorithms are a little different, so I think I'll share those with you just to see. You had talked initially to me about maybe us testing some of the things in our office, and she's going to go live in the next month or so. She's getting QI approval right now to do her initiative.
That would be great. I would love to see the algorithms that you're coming up with.
It's basically, a lot of it's based on the Oregon stuff and your website, of course, but we're trying to keep it simple, and we're trying to do it every single time and having the nurses adopt it as a vital sign. So I'm very excited about this, and I just thought maybe in your algorithm there was a little ambiguity with the 2 in the middle. So that's something that we're trying to keep it simple. So I think it might be interesting to see, where you go with this one and then kind of what we're doing and then see what's effective.
Yeah, like I said, anybody who has any ideas of this is not a go live. The One Key Question folks, of course, they have ownership of this algorithm. And we're just kind of helping and advising and trying to operationalize it, utilizing people's experience with it and the challenges of incorporating it into routine care. There's a lot of people who are trying to do this, and as you know, there are multiple barriers to doing it well. And so all different ideas and approaches to be a part of the conversation would be welcome. Thanks, Jessica. I'm sorry I didn't put your info on there.
That's pretty impressive, Jess. I don't know. It looks like you wrote that backwards. Good job.
Sorry. There are some people on the line who I know are not on the implicit email distribution, and so I know that some people forward the invitation onto colleagues, which is excellent. I just wanted to make sure that people were in the loop for future communication. So if this is your first webinar, if you could just shoot me an email so that I can include you on future communication, that would be great.
And then this will obviously, I'm assuming this will go out, so if we want to kind of use some of these slides for teaching and things, that would be available to us?
Yeah, so this will go out in the next implicit newsletter, which will go out this month. And we're also recording, so the recording will also be available.
So Dan, let me just throw out briefly, I think a strategic next step to energizing family medicine, and that would be working with the AFMRD, the Association of Family Medicine Residency Directors. The great majority of directors get together for a couple-day meeting in early April, and I think there's timing to see if we could work with Stan Kozakowski and the current president, Jim, blank his last name, from Bangor, Maine. I think if we could get a plenary at that session when you've got 300 program directors there, and just really talking about that this is a family medicine thing. It's not OB, anti-OB. It is a family medicine core issue. And if the great majority of them could really get it and take it back to their family medicine residencies, I think there would be a tremendous potential multiplier effect.
I think that's a great idea. So I'd welcome that that connection, Steve, and I'll leave that to you to see if we can, if that can be a platform we can reach.
I'd be glad to do that.
Any other questions or comments or thoughts?
Many of you know about the Family Center Maternity Care Conference. Dan will be a plenary speaker on preconception care, and will be helping to do 2 workshops on the preconception care for women with chronic medical conditions. So it's just important that everybody realize that that's another of a national forum that will be happening in August of this year.
Wow, congratulations. Good job, guys.
Well, and Steve is humble. He's the one who is actually chairing the entire course, and so it's his initiative in making sure that preconception care is front and center. So it's kudos to Steve.
That's pretty phenomenal. That's awesome.
Any other thoughts or comments? Any thoughts from the March of Dimes folks? We always so much appreciate all of your support and in moving these ideas forward. And for those who are not aware, is that we are in the final stages of the implicit toolkit funded by the March of Dimes, and that is hopefully going to be finalized and published this summer.
Hi. Kudos for a great presentation. Just wondered about the data reporting, and so what you mentioned about the measures and the new reporting that different sites could do, is that going to be funneled into the Title V systems across the state at all?
Well, so the idea around these preconception wellness measures is really going to be system dependent. So each system, each clinic currently is responding to CMS in different ways of reporting measures based on their healthcare system or their clinic type or the goals. So the idea is presenting these as options for systems to start to think about them and report them to themselves. I mean, they are not incentive-based, so this is not coming from CMS. This is coming from us, the National Preconception Health and Healthcare Initiative. Of course, it would be awesome if an organization like the National Quality Forum took these up, but that's a different process entirely. And so we wanted to get these out sooner than what it would take to go through a process like that to get these validated or sanctioned by these national organizations. Well, the reason why we did it that way is that organizations were coming to us really asking for preconception care measures. And there really wasn't anything that we could provide because, again, preconception care is so comprehensive. And so that's the task we underwent, is to give guidance to systems who are interested in starting to measure preconception care. And the first place to measure preconception care is to start to report upon these indicators of preconception wellness that then could create preconception care measures for individual organizations or clinics that would feed into it. So the idea is for systems or clinics to begin to do this on their own. Again, most of these measures are already being reported upon in different forms already. So it's really just about a choice to start to report them, not necessarily doing something majorly new.
Thank you.
Any other thoughts or comments, questions? Certainly email me if you have any other thoughts and or get inspired or have a new idea. That's how these things keep moving forward. So I appreciate the time and the opportunity to present some of this stuff, and I look forward to more conversation in the future.
Well done, Dan. It's Ian. I really appreciate your presentation.
Thanks, Ian.
Thanks a lot, guys. I really, I think this is awesome, and I'm hoping everybody's planning to be here in Pittsburgh because we're going to have a big implicit party gathering. Sharing of the minds, as we always do, but I'm local, so we're going to hopefully make it a little more intimate and have some good conversations.
Great. Thanks, Lisa.
Thank you very much. Have a good day. Got to run.
Take care. Bye-bye.
Bye.
Bye-bye.